Let me talk to you very briefly about the different kinds of operations that we do, and as you might imagine, the different operations are different because the tumor does occur in different parts of the pancreas. So I'll talk to you about three operations. The first is the so-called distal pancreatectomy, which means that if the tumor is in the body or the tail of the pancreas, we remove that part of the pancreas. It's called the distal pancreas. This is relatively straightforward compared to the Whipple type operations because all we really need to do is cut across the pancreas somewhere on the patient's right side of where the tumor is and remove the tumor. We remove not only the tumor, but the spleen that is associated with the tumor, and this is done in an effort to remove those tissues into which the tumor, the cancer, may have already spread. And this shows what the picture would look like once the tumor is removed, the spleen is removed, and this is just meant to show how that edge of the pancreas across which we made the cut has been sutured closed. The next operation is an appropriate operation to do, and this is the one we do most of the time, if the head of the pancreas is where the tumor is. And in fact, that's the case most of the time. So what this picture on the left shows is that we, in a manner of speaking, cut on the dotted line or the dashed line. We remove the gallbladder, we remove about half of the bile duct, we remove about a third of the stomach. We remove all of this, the duodenum, and a little bit of the intestine at this point. And of course, we remove the head of the pancreas with the tumor in it. The picture on the right shows two things. It shows what's left after all of that tissue has been removed, and it also shows how we put things back together. One eats and drinks again. The food goes into the stomach as it used to do. There's less stomach now, but it still goes into the stomach. The food and the liquid empty from the stomach and into the intestine. And while all that is occurring, the pancreas is doing the things that it's normally supposed to do, secreting the enzymes, secreting the insulin, the bile is entering the small intestine. All of these mix, and they mix with the food, and people live and are well again after they've recovered from the operation. But the operation we do all over the world now, in the majority of cases, is not the standard operation that I just described. The idea arose that if you would not remove any of the stomach at all, and not remove the little valve at the end of the stomach that helps to control the speed with which food and liquid empty from the stomach, the so-called pylorus. If you would preserve these, that the quality of life would be better. What's different about this? Well, the difference is that we don't take out any of the stomach at all. We don't take out the pylorus, which is hidden here, and we leave intact just a little bit, a couple of centimeters of the duodenum. This is obviously a cutaway view that shows this little valve that I've talked about several times at the end of the stomach that helps to control and usually to slow down the rate of gastric emptying. This is the Pylorus-preserving operation. So this is the same, the pancreatic connection, the bile duct connection, but what is obviously different is that the stomach is intact and the pylorus is as well, and that's where the connection is made. The mortality rate isn't 20 or 25%, it's 1 or 2%. And I'm pleased to be able to tell you that at UCLA over the last, I think, 10 or more years, it's actually been about 0.4%. So it's really very, very, very low. The other thing that keeps people coming back for these operations is that the sad truth is no one has ever been cured without having had the operation to remove the cancer. We can tell them nowadays that operation really can be done safely. that the quality of life after they recover from the operation is likely to be excellent, that after the operation and after recovery from the operation, all is not over. The rest of the treatment still needs to follow, which is adjuvant chemotherapy and in some patients radiation therapy. We can't say that we've reached the stage where with colon cancer or some of the other kinds of cancer, 70 or 80 or 90% of the patients have a likelihood of being cured. But as I've said several times now, better drugs are on the way. And I think with that, I'll stop. Thank you very much.